Thank you. Thank you very much, David. A lot to discuss. I think we're going to, because of time, we're going to move on to the panel. And so Dan Maxwell, you can come up and I'm going to find. So Dan is, as of the last few months, a professor emeritus at Tufts University and the former Henry J. Lear Professor in Food Security. He's a leading scholar on famine, food security, livelihoods, and humanitarian crises, and a founding member of the IPC Famine Review Committee. He was also, of course, the commissioner on the report himself. So Dan, over to you for panel one. Thank you very much for coming. You have to turn on the sign.
Okay, thank you. Can I invite my fellow panelists to join me? We have one panelist who's online and three in the woods. And let me introduce him. The order in which I will call on him. What we will do after the introductions, call on each of the panelists, a question or two, and set the tone, and then we launch the questions for discussion from the and we can brother. Paul, I will count on you to give me a signal about our. So to my close it. Is that better? Thank you. To my immediate left is Dr. Moumini Niaoné, a physician and public health leader from Burkina Faso and a PhD candidate here at Johns Hopkins University. He's the founding executive director of Pull for Progress and has led community health initiatives for displaced and crisis-affected populations in Burkina Faso. To my far left is Dr. Orit Abrahim, who's a general surgery resident at Mass General Hospital in Boston and a research fellow at Harvard Medical School. Dr. Abraham works on health systems, surgical care, and health delivery in complex emergencies and displaced populations. And if I may note, both Dr. Moumini and Dr. Orit were two of our next generation scholars, the younger members of the commission. And to my right is Dr. Chiara Altare, who's an associate research professor here at Johns Hopkins University and the School of Public Health and core faculty at the Center for Humanitarian Health. Dr. Altare's work focuses on humanitarian emergencies, population displacement, infectious disease outbreaks, and operational research. And online, if we can maybe get her picture going, is Dr. Joanne Liu, who is a pediatric emergency physician and professor at McGill University in Canada. Dr. Liu is former international president of Médecins Sans Frontières and has led major humanitarian and health emergency responses, including during the West Africa Ebola outbreak. Are we able to get Joanne? Okay. So we're turning first to there, Joanne. Hi, Joanne. We just introduced you. Okay. Turning first to Dr. Moumini. The Commission calls for inverting power and centering affected communities in humanitarian health responses. In context of conflict and forced displacement, where communities may be fragmented, traumatized, politically constrained, or internally unequal, what concrete mechanisms can ensure that this shift is not merely symbolic localization, but a real transfer of decision-making power, resources, and accountability to displaced and conflict populations?
So thank you for having me. To me, I would approach this question with a lot of humility. I will approach this response with humility as the humility that guided this report, because it's not an easy question like a ballot. We don't have a magic ballot or a one-size-fits-all solution. But what is possible will always depend on local context, the typology of the crisis, the level of violence, and the degree of institutional collapse. And to me, we must begin with an assess-based perspective and not see affected communities as just desperate group of people who are waiting to be rescued. One of the leading experts in global health, Dave Taylor, said there is no universal approach to community health problems, but there is kind of universal there is no universal solution, but there is a universal approach, meaning starting with the community. And so to me, we have to start where the community are and build on what they have. And one of the best examples I have is the Sudanese Emergency Response Group. That is a group of volunteers who started where the government or international organization couldn't even have the people, showing that communities are like an adaptive system that will self-organize. And we should be looking this as a key, an important future of communities. And to me, we need to recognize the legitimacy and protecting them from harm, financing them directly and flexibly, involving them in real decision making. And this is, to me, to build a plural, protective, and inclusive mechanism that allow different voices within the community to influence decision making. I'm saying that because it's not only consulting communities, it's giving them the voice to ask who is making the decision and to ask and shape those decisions and be involved. So accountability is in both directions. They should be asking why decisions are made and what can be changed.
Thank you very much. You are one of the next generation scholars, the younger colleagues on this commission. I'm just curious, from your perspective, does the experience of serving on this commission make you feel more hopeful or more worried about the future? Humanitarian action and health for all.
So I would say it's made me more optimistic and hopeful. Thank you. Because first of all, being surrounded by leading experts like you, for Dr. Spiegel and other professors is a humbling experience, but very inspiring. I witnessed a very diverse group talking, discussing, disagreeing, and agreeing on different topics. And this convinced me that having a multidisciplinary group, looking at a problem with different perspectives is an important key. And not only public health, but any solution should be addressed with a multidisciplinary lens. So that gave me a lot of hope. And I was in a group where Paul Spiegel will ask you, what do you think? And it's not just asking to ask, but he means to listen. And this is, to me, a vicarious experience of leadership. And that's a good experience I give. And to me, what I would add very quick is I saw a commissioner and next-gen member engage with uncomfortable questions, hold different positions, debate respectfully, and move toward consensus through several rounds of discussions. That process was rewarding, humbling, and deeply inspiring. And I saw that this report emerged from not only technical document, but from a decade of first-hand experience, scientific evidence, ethical reflection, and practical wisdom that reflects people choosing conviction over convenience, offering guidance for action and decision-making. That makes me hopeful, and I hope this report will close the gap between knowing what to do and really doing what has to be done. Thank you. I'm very hopeful for that.
Thank you, Dr. Moumini. Dr. Orit, if I may turn to you next. One of the strongest arguments in the Commission report is that this is not simply a funding crisis, it is a political and structural failure in how humanitarian health is financed. From the Commission's perspective, what fundamentally needs to change in the financing architecture if we want a system that is equitable, sustainable and actually responsive to people affected by COVID.
Thank you, Dan. And I'll say that it's also humbling to speak after Moumini and meeting all the next gen scholars and working with them. And so you're right, you bring up an important point that financing, we don't just have a funding crisis, we have a crisis in the way that funding is organized. So the way that resources are managed, allocated, and mobilized is what influences who sets priorities, who is participating in decision-making, and who shapes accountability. So an important thing that the Commission brings up is that financing is a governance issue. And we do need these small technical reforms, but we also need a vision to transform the architecture. And Paul mentioned many of these weaknesses that we see in how humanitarian help is financed today. So first, we see that aid is not allocated based on objective need alone. It's still dependent on a small number of voluntary public donors, namely the EU and the US. And it's very vulnerable to geopolitical interests and shifting political priorities. We see that it's still relying on multiple layers of inefficient intermediaries, and local actors are still receiving a very small share of direct financing and limited influence in their decision-making. And what we're seeing is overall just has been too slow, too inflexible, and too fragmented to really be responsive enough to these evolving contexts and crises. And a volatile funding landscape has real consequences for health. So continuity of care is disrupted, services collapse, and we're missing real opportunities to invest in local institutions and strengthen health systems. And we're seeing this pretty starkly in the past few years. So these recent funding cuts are projected to cause substantial increases in excess mortality. And it's not just increasing violence alone, but it's interruptions in public health services like nutrition, WASH, and maternal and child health care. But at the same time, we're also seeing in countries like Afghanistan and Yemen, people are paying for a majority of their health expenses out of pocket. And these are contexts where decades of humanitarian assistance has been provided. And so we're really begging the question, who is the humanitarian financing system designed to serve ultimately? And that's why our recommendations are focusing not just on raising resources, but on changing the way that decisions are made about where they go. And so first, we're proposing a more independent and transparent pooled fund that can allocate resources based on need and act more quickly before crises escalate. And we're calling for a more diversified and broad funding base that includes innovative financing instruments where they're appropriate. Then we're emphasizing transitioning into national health and social protection systems that are inclusive of these displaced communities so that humanitarian assistance is supporting long-term resilience and it's not just running in parallel to it. So I'd say the common thread across these recommendations is that financing should not only build systems that are sustaining health in crisis and responding to shocks, but it should be building real mechanisms to transfer decision-making and accountability closer to affected populations. So I'd say from our perspective, a more equitable and effective system is one that centers affected populations, not donor priorities or institutional incentives as the center of financing and governance decisions.
Thanks. You mentioned the financing as a form of governance. What does shifting power actually look like in practice?
That's a good question because shifting power can sometimes seem a bit abstract. The Commission was very intentional in placing inverting the power as the first recommendation, and that's because it really underpins the following actions that we're calling for in ending impunity, fixing the financing architecture, and upholding health for all. A few ways that we can see that in the financing architecture are first changing who controls the resources. So this means not only direct financing to local and national actors, but also investing in building their institutional capacity through such things as predictable core funding and really genuine partnerships that are transferring responsibility, that are not just transferring responsibility, but also transferring resources. Again, it would be to change the way that allocation decisions are made. And so not only should allocation decisions be guided by impartial and unbiased needs assessments that are done at the subnational level as well, but by making sure that local actors have a meaningful role in setting priorities and they're not just implementing decisions that are made far away. And third, I would say it's strengthening accountability at all levels. And that could look like more inclusive governance structures that can represent affected communities, It's by leveraging technology so that we can track where funding is going to which specific public health programs and how much is going directly to these frontline responders. And it's also looking at collective health outcomes as how we're measuring success and not just financial outputs. And I think finally, it would be ensuring that in these protracted crises, that humanitarian actors are not building indefinite parallel structures. It's thinking from the outset about how we will transition operations and social services to locally legitimate authorities, and external actors who have any operational role in the planning stages are making these clear and safe exit strategies.
Thank you, Dr. Orit. Dr. Duane-Liu, if we can turn to you for a moment. You spent 30 years in the field as with Médecins Sans Frontières, and you're now commissioner on an ambitious humanitarian health report. Looking back over those 30 years and looking at what this commission is demanding, what does the humanitarian system consistently refuse to confront about impunities for attacks on healthcare on the medical mission, and what would it actually take to change that?
Hi, good day, everybody, and thank you for the question. I think that when I look at those 30 years is the fact that this always has happened throughout the time I've been working in the field and still today. The difference is today we have massive documentation on attacks on healthcare, but unfortunately, we don't have any consequences to that. As the commission is reporting, there's 663 incidents in 2024. But if you were to look as well on the WHO index on attacks on the medical mission, it's increasing each year. And what is interesting, though, is in the last year, from 2024 to 2025, is the fact that there was a bit less attacks, but there were more casualty in terms of civilian people, meaning that somehow we are not sparing the civilians as we are waging war. So, so what is really interesting is according to WHO is 81% of the attacks on the medical mission are led by states, not non-state armed group, but by states. So I think for me, what is the most striking thing is that the most serious violators in terms of attacks on hospital are the most protected actors. What do I mean by that? Is the fact that if you take, what happened in Syria, is we know that there was one of the P5 country, Russia, who was part of the country who was attacking some of the hospital. But there was no consequences to that. But not only there, it was the same thing in Gaza, it was the same thing in Sudan, it was the same thing in Yemen. So I think that it's important to bring that under the spotlight and see how much we are complacent as well in terms of putting under the spotlight non-state armed group when they do attacks versus when it's a state that can be protected. They can be protected to, for example, a veto vote on the UN Security Council. So the other thing is that I see is the fact that I find there is more and more. I come from an organization who are speaking up, and which is MSF, Médecins Sans Frontières, and then sometimes we pay the cost of that. But I see there's a lot of calculated decision in terms of being silent about documented attacks. And sometimes it's to preserve access, it's to preserve operational humanitarian space, but it's becoming more and more, I would say, an institutionalized somehow posture. It's what I call the cash sex, like we do it because that's as well easier. And I guess the other thing is the fact that I think that the commission is trying to address, what needs to change. But for me, what needs to change is yes, IHL needs to be operationalized in the terms that it cannot just be sentences and words, but this is not what is happening. We need that when there is violation, there should be clear political and financial consequences to that, and this is not enforced. And then but I really like on in the commission the fact that we use the health outcome as a concrete indicators of compliance. somehow it's a bit more real. And I think we come with the proposal of a standing global health protection alliance. I'm not sure who will raise their hands as states to belong to that kind of alliance, but I'm open to that. But just to summarize, I think as long as humanitarian financing, it will be concentrated among donors whose military allies or themselves are attacking health facilities, I think the incentive for silence will outweigh the normative commitment for accountability. And that's our biggest challenge.
Thanks. Attacks on healthcare, obstruction to humanitarian access, disregard for civilian population, et cetera, are all increasingly normalized. But what has changed over the past 3 decades that make that the case?
Well, I think that Paul has mentioned it, as well as David Miliband. I think the conduct of warfare has changed. I think he has moved into urban warfare in densely populated areas. And so therefore, not all the precautions are done to spare the civilians. That's one thing. But as well, the technology makes it difficult. The enhanced technology is somehow bringing a dehumanizing aspect to the way we wage war. But I think one of the key things that I've noticed is the fact that the narrative has changed. I think in the past, when someone will bomb a hospital of a country at war, there would be some sort of excuse. People would try to find an excuse at the very least. There would be an excuse narrative. But today we don't even have that anymore. Today we have more like, I think you've lost your protection, meaning you probably deserve it. And so that's what as the slippery slope that we are being engaged right now. I think that we are in the crazy, I would say, paradox of having so much precise documentation on attacks, but I have no real political accountability for that. And as long as this will happen, as long as there would be no cost, no political cost, no financial costs, no reputational costs, it's going to be hard. It's going to be hard to stop the trend. So for me, that's the main thing. And then, as I said, the financing of humanitarian action has become very politicized. And the people who are financing, the big donors, or as well the people who are breaching the rule of IHL and attacking hospitals. So we are in a difficult posture. And as Richard Horton has mentioned it's we may have this commission as defined the what, and I think the how is going to be a long journey.
Yeah, thank you. I recall early in my humanitarian experience, it almost seems quaint now, but in the Sudan Civil War, the Sudanese Air Force would avoid bombing ICRC hospitals, but felt happy to bomb NPA hospitals because the Norwegian People's Aid Organization had openly decided to side with the rebels in that war. Such a distinction, I don't believe, exists anymore today. Finally, let me turn to Dr. Chiara Altare. In the Commission report that presents outcomes and indicators for each of the Commission's recommendations, did the Commission discuss how to define and measure the performance of humanitarian action? And if so, what are the key messages in this regard?
Sure. Thank you, Dan. Yes, Nick. So one of the working group of the Commission focused on the performance of humanitarian action. And I think what we wanted to do was, in a way, trying to see how so what are current evaluation methodologies, evaluation frameworks, and why are we evaluating and how humanitarian action, and to what extent we are using such evaluations to measure performance. So are we using them for as a way? Could this be a way to operationalize accountability? And so trying to respond to this question, I wanted to highlight 2 points. One is that we look at the definition of success. And so far, I would say in the current practice, we look either at effectiveness, and I think we mentioned many times how important it is to indeed implement effective interventions. And so one aspect of performance is how well the intervention achieves the results that we would like the intervention to achieve. Or we look at often donor-driven accountability, basically to what extent a project was implemented according to plan. So you were funded to do 10 things, how many did you do, and how well, how quickly, or how well did you match the plan? And it's very rare to see system-level assessment or system-level, evaluations of how the response is doing beyond the individual. This intervention is very well conducted and is effective, or this organization actually implemented what they were supposed to do. And what the Commission argues is that basically this is no longer enough. So it's not enough to see and to say, oh, this intervention is very successful, if then at the system level, as we said, the communities are not defining priorities, are not in charge of the response, if funding still remains mostly in international donors, or if there is no accountability, and as we mentioned multiple times, if health outcomes actually really don't improve. And the table that you mentioned then tries to provide 4 system-level outcomes that are indeed linked to the 4 recommendations, and then provide a few illustrative indicators that could help monitoring or track the progress against this, so how well we are implementing the recommendations. And what I wanted to highlight is that 3 out of the 4 outcomes are actually not strictly focusing on health, because exactly as we have been saying throughout the Commission, there are some systemic points that cannot be ignored. So we can't not look at, again, involvement of at impunity or accountability or communities, and only if we achieve certain outcomes that are, again, not made as systemic, we can improve health outcomes. And so one second point, because it's been mentioned both by David, by Joanne, and by Paul, one of the recommendations focuses on using health outcomes as accountability indicators. And I think this is, in a way, it may sound obvious, but actually we are not doing this right now. And so I think that's why it's so important as a recommendation, and it has at least 2 implications. One is, so if health outcomes were used as accountability indicators, and I think this is what, I don't remember, Paul, you said, or Joanne, interruption of healthcare, or excess mortality, or also preventable harm, these are no longer bilateral effect or collateral effect, because this is what happens in war. This is a measure of our failure. So it's a measure of governance failure and protection failure. And I think it becomes different if we, it's our fault now suddenly because we are not able to protect the population we wanted to protect. And then I think the second point, which is also linked to what David was saying earlier on. So again, if health outcomes are now accountability indicators, we actually have to measure health outcomes, and we actually have to show that we are implementing evidence-based interventions that are leading to some benefits. And again, this is all sounds maybe trivial, but the reality is that we are not measuring health outcomes enough or regularly enough, consistently enough to be able to say this intervention is achieving. So the specific interventions might, but as a response or as a community, we rarely know how well we are doing. And then it remains problematic because we cannot really say, oh, we are here to save lives and to improve lives, but then it's very difficult to prove that that's what we are doing.
Thanks, Chiara. Paul mentioned that there were some 533 key informants that we spoke to on the commission. To what extent was that issue discussed with community members, or as with other key informant interviews that you conducted, and what are communities saying about this?
Yes, so there wasn't a specific question on performance, because it's often a very technical term that might not mean much in reality. But what we heard was a lot of, or some sort of disappointment, I would say, in terms of the mismatch between the interventions that were implemented, but then the needs that the communities were raising, and how basically their needs were not really met holistically. I think the biggest problem is often that we are focusing on specific needs, and therefore we are providing a service that solves these specific needs. But as soon as either the need is over or you have a second need that we didn't think about, then you will remain. So the needs of the communities are not met. And I think the second problem is often that, as we have been saying, this crisis has become so long that needs are not only the most acute ones. So when a situation becomes protracted for 10 years, 15 years, over such an amount of time, you don't only need basic services. You need to find a way to educate your children, to live, to gain your own dignity again, autonomy, etc. And I think this mismatch will remain as long as we don't include even more and we really ask how can we improve this situation, and therefore starting with defining success and defining needs from the community side.
Thank you very much, Chiara. Paul, how are we doing on time?
Good, you have another 10 minutes maybe for questions.
Okay, thanks. We'd like to open it up to questions or discussion points from anyone attending, at least attending in person. I think it's going to be a little bit difficult to do it online. There is, back in the middle of the room where Makiba is standing, a microphone. So if you have a question, please feel free to just go to that microphone and pose the question. We'll take maybe 2 or 3, and then I'll ask the panel to respond. If it's a general question, I'll try to direct it the best I can to the panel member most able to address it. But if you have a question that's specifically for one of the panel members, please indicate so when you pose your question. And if I may ask you to also introduce yourself, state who you are and where you're from. And don't everybody jump at once. Yeah, please. Please just go to the microphone. Tell us who you are and tell us your question.
Well, I'm Tom. I guess you need more than that. I'm Tom Carson. I'm not affiliated. I've worked in many of these places over my career, starting in Bosnia and most recently, not present, but in Yemen, doing an evaluation of AAP practices. So I'm familiar with it. A lot of this I've heard. I've known for decades, different themes. I think I've liked a lot what your person up here said. I was doing looking down at the paper, but I just want to, I guess, raise another point. If you look at the impunity part of it, and of course fix the finance, there's the political will, and of course it doesn't seem to make too much sense to talk about political will in this time. But beyond political will, there's social will. So I'm wondering, at some point, something else has to drive it besides talking to each other, to people who are already familiar with all this. So I guess some thoughts people have, not necessarily here at this time, but how do you make it matter to enough people to drive some kind of action to make the political will even happen, besides, funding appeals from IRC or whoever, which are all very good to get people to donate. But, those are always somewhat limited to the degree that it's needed. How do you drive change in real time? Because I look at the future here, of course, and elsewhere, and it looks like it's going to get a whole lot darker before it gets any better. And so I'll just stop there. It's just a comment.
Please.
Yeah. Good afternoon, everyone. My name is Lisa Niaoné. I'm Executive Director of Core Group, and I've been a humanitarian since the early 90s. We've had different initiatives throughout the years. We've had the WHO help as a bridge to peace. So many different recommendations, and I applaud the efforts of this incredible commission, as well as the people's voices that were actually captured, those 532 from around the world. My question, what is the operational plan to get us there? We are in a high crisis world with multiple political events happening that are making it more challenging, I think, than ever. And we all here want action. So how are we going to get there together? What are the next steps? How can we be involved beyond advocacy? Thank you.
Thank you. One more question, yeah, please.
Good afternoon. I'm Judy Bass, part of the, do I need to make it down? Part of the Johns Hopkins Center for Humanitarian Health. I'm curious to hear thoughts on the regional variations. So a lot of the conversation has been broad about global issues. And as Paul pointed out, the launches, the conversations will happen in different regions of the world. And the contexts are different. The crises, the politics, the issues in South America are different from the ones in Africa, are different ones in the Middle East, are different and have different histories and have different cultures and have different politics. So I'd love to sort of hear thoughts on taking these things and also acknowledging context and the role of context and the variations that may need to come in and whose voices and so thoughts on how to sort of move those policies forward, not just at a global level, but also at the regional.
Yeah, great question. Thank you very much. I think maybe given time, what I'd like to do is try to summarize those three questions into one and then offer each of the panelists a chance to reflect briefly on those, if I may. The first two are actually quite, in a way, quite complementary to each other. One is about what is political will? How is political will mobilized? How do we make this happen? The second one is about is there an operational plan? How do we if even if we have the political will, what are the actual steps we need to take, whether incremental or otherwise? And then the last one is how do we account for regional differences, for context specificity in the context of perhaps a global polycrisis, but with a lot of variation in different contexts on the ground. So let me just quickly run back through each of our panelists. I'll ask you to maybe limit yourself to a minute or so. Well, let's just go in the same order as we went to begin with. So Dr. Moumini, do you have any thoughts on this?
Yeah. I heard the first question about social weight. To me, the social, I would say, immobilism can be translated as a failure of localization. When people in the ground still feel that the budget cut is just a problem of big institutions, organizations, as you see how much goes to the grassroots organization and communities, they will not mobilize enough. That's what I feel. And if we have more localization, if we empower people, it will be different. If they are empowered enough, the accountability, they will ask for accountability, and we will have more social mobilization that can move politicians. That's what came to my mind. And I think localization, a true one, is one of the key solutions to political movement. I will stop.
Excellent.
Mm-hmm.
Sure, I think I can speak a bit to the operational plan. So what's next for the commission? And I'll speak from academia because academia is currently my home and what we can do. The commission hopes to mirror what we're doing with the regional launches and set up these humanitarian operational hubs so we can generate evidence, we can work across political lines, we can try to figure out how to make localization concrete in practice. And so we're hoping that by kind of disseminating the work and implementation, we can start to make more context-specific goals and targets.
Thanks, Orit. Dr. Doolin, any thoughts on those three questions?
Hi. Yeah, I think I'm going to give it a try on the political will. My experience is limited, but I remember when we were facing a lot of pushback after the attacks on Kunduz in Afghanistan on October 3rd, 2015. And we were saying, well, there's a trend and there's more attacks on hospital. What happened is basically we had a group of country champions who decided that there needed to be a political signal that there were still rules in the way we wage war. And so these were the elected states in the Security Council back then. So I think that if we want for anything is you're going to need to have states champion that will be ready to take the pressure, the flak, and the intimidation. That being said, but it's a long time ago, and it was such a different, I would say, dynamic in the world. Is if we look back at some of the fight that we won in the past, we won the fight on generics, with HIV, and it's because of all the community in so many countries have rallied together and have really pushed together. So I think that I will ask for new state champion, and I would ask for a much more committed and strong community investment at grassroots, because it did happen. We did it with ARVs and generics in the past, and I still think we can do it again.
And finally, Chiara.
Thank you. Maybe just to add 2 points. One, based on what Joanne is saying, and probably, so I think it is a negative period and it's a very depressing one, but there are cases like Spain. So probably we can hope that eventually things will change, and we have to continue, building the evidence that Orit mentioned, and providing information and ensuring that facts are still stated. And then when there will be a different political scene, probably we will be able to do more. But I think we can't wait for the political change to happen, or the governmental change to happen for implementing our work. And then I think the second point could be one other very successful commission. So Lancet commission was the what then was implemented with the countdown. So the countdown initiative managed to track progress on coverage of services, on climate change, et cetera, and this has actually become a milestone, or a very important report that is published. Don't quote me on this, I don't remember if it's annual, every 2 years or something, but it is something that the community is now referring to and looking at. And so I'm hoping that we will be managed to set up mechanisms where we will be reporting and monitoring indicators on how well we are progressing and how well we are implementing all of this. And I think, again, also don't quote me on this, I don't remember who said, but what is measured becomes more visible, and it is counted. And it doesn't mean it's the only thing that counts, because then we go back to the usual, how do we integrate, qualitative appraisal and everything. But monitoring and showing progress, I think, would also be a way to draw attention and build argument, and hopefully bring in and convince people and governments.
Thank you very much, Chiara. I think in the interest of time, I'll hand it back to Paul, but please join me in thanking our panelists.
Thank you. Thank you all. Thank you, Dan. Why don't you all come on up? Jeremy, Anine, Hiba,